Hello everyone, welcome to the Academy of Online Radiology Education. My name is Sara Momtazmanesh and I'm a postdoctoral research fellow in the Department of Radiology at Johns Hopkins University. I'm truly excited to be here and to contribute to the ACORE blog series. Today we are discussing long-term risk after ST elevation myocardial infarction and specifically what cardiac MRI and machine learning can tell us that our current tools cannot. Before we begin, I want to thank my senior editor, Dr. Gozi, for his contribution and guidance on this work and express my gratitude to Dr. El-Sayes for his valuable guidance and continued support of the ACORE blog series. The paper we are presenting today is titled Machine Learning Using Clinical and Cardiac MRI Features to Predict Long-Term Outcomes in Acute STEMI, published in Radiology in February 2026. STEMI, or ST elevation myocardial infarction, is a life-threatening emergency caused by complete occlusion of coronary artery. Even after successful reperfusion, the long-term risk of major adverse cardiovascular events remains substantial, and long-term risk prediction in these patients remains an unmet clinical need. Risk stratification, which is identifying who is truly at risk for future events, is essential for guiding follow-up intensity, therapeutic decisions, and monitoring. The two tools we currently rely on for this are GRACE and TIMI. GRACE, or the Global Registry of Acute Coronary Events, was designed to predict in-hospital and 6-month mortality. Additionally, TIMI, or thrombolysis in myocardial infarction, was designed for 30-day mortality prediction. Both of these scores rely on variables collected at admission, including age, heart rate, blood pressure, kidney function, and cardiac biomarkers. Neither score incorporates imaging. They rely solely on clinical and biochemical variables available at admission, and critically, neither was built to predict what happens over the next several years. On the other hand, cardiac MRI is a gold standard for quantifying infarct size after STEMI. It provides a rich multiparametric dataset spanning ventricular function, myocardial strain, tissue characterization, and atrial parameters. Yet most prior machine learning studies in this space relied on clinical and laboratory variables alone, or only on a handful of conventional cardiac MRI parameters. No prior study had integrated the full multiparametric output of cardiac MRI, including biatrial and biventricular strain, within a large-scale, externally validated machine learning framework. This paper addresses that gap directly. The investigators used a two-center design with training and external test sets drawn from 2 independent hospitals in China. The training set involved 682 patients between September 2015 and September 2023 with a MACE rate of approximately 21%. The external test set involved 384 patients over a similar period with a near identical MACE rate of 21%. Patients were included if they had acute STEMI, underwent cardiac MRI within 7 days of percutaneous coronary intervention, and had PCI performed within 12 hours of symptom onset. Patients with prior myocardial infarction, non-ischemic cardiomyopathy, known structural heart disease, or poor image quality were excluded. With the cohort established, let us now look at the variables that went into the model. The investigators started with a pool of 67 candidate variables spanning 8 domains: clinical and demographic data, laboratory biomarkers, left ventricular function, LV tissue characterization using late gadolinium enhancement, LV strain, RV function, RV strain, and biatrial strain. Before any data-driven selection, 4 variables were locked in a priori. The authors decided upfront, based on established clinical evidence, that these would enter the model regardless of what the algorithm said. Those 4 are age, clip class, which is a measure of heart failure severity at presentation, left ventricular ejection fraction, and infarct size. The remaining 63 variables then went through recursive feature elimination, which is a method that systematically removes the least informative variables one step at a time until only the most predictive remain. This process selected 15 variables. With the 19 variables identified, the investigators built a predictive model in 3 steps, as shown in this figure directly from the paper. Step 1 was data collection, the 67 candidate variables gathered from each patient. Step 2 was feature selection, the RFE process we just discussed, narrowing the pool to 19 variables. Step 3 was model construction and evaluation. 3 machine learning algorithms were compared: logistic regression, random forest, and LightGBM. LightGBM achieved the highest training AUC and was selected as the final model. Its key advantage is the ability to detect nonlinear interactions between variables, relationships that conventional statistics assume do not exist. The model was then applied without any modification to a completely separate external cohort for validation. In the independent external test set of 384 patients, the machine learning model achieved an AUC of 0.91, compared to 0.66 for GRACE. That gap is not marginal. In practical terms, the model correctly identified more than 4 out of 5 patients who would develop a major cardiac event and correctly classified more than 4 out of 5 who would not. 2 things are worth emphasizing. First, even the clinical model using only routine established parameters already outperforms GRACE substantially. The machine learning model improves further on top of that, confirming that the full cardiac MRI dataset carries independent prognostic value beyond what clinicians currently measure. Second, performance was render independent across all 3 major scanner manufacturers. This slide asks a different question, not just whether patients will develop MACE, but when. The machine learning model achieved a time-dependent AUC of 0.92 at 12 months and maintained 0.92 at 48 months. No degradation over 4 years. GRACE drops to 0.67 at 48 months and TIMI to 0.61 because both were designed for short-term prediction, not long-term risk stratification. The most important comparison on this slide is the RFE Cox model. It was built using the exact same 19 variables as LightGBM, but used Cox regression as the algorithm instead. AUC 0.89 versus 0.91, a statistically significant difference. Same inputs, different algorithms. The advantage comes from LightGBM's ability to capture nonlinear interactions. Finally, performance held consistently across both endpoint types: hard MACE, which includes cardiovascular death and recurrent myocardial infarction, and other MACE, which covers revascularization, a stroke, and rehospitalization. The authors applied SHAP analysis to quantify each variable's contribution to the model's predictions averaged across all patients. Infarct size and LV ejection fraction led as expected, but their relationships differ. Infarct size is near linear, while LV ejection fraction shows a threshold effect pronounced below 40%. Beyond those two, intramyocardial hemorrhage, microvascular obstruction, and RV strain each contribute independently, capturing dimensions of post-infarction injury that standard imaging parameters alone cannot quantify. And then there is left atrial reservoir strain, the most novel finding. This is the first STEMI machine learning study to include biatrial strain, reflecting atrial remodeling from chronic LV dysfunction. These findings reveal an independent prognostic layer that no prior risk score has captured together. The next step was translating the model into something clinicians can actually use, a risk score derived from the contributions of all 19 variables. 3 tiers emerge. Low risk carries 2.3% annual MACE rate, intermediate risk carries 5.8%, and high risk carries 12.3%, more than 5 times the low-risk group. The Kaplan-Meier curves tell the same story. 3 groups that separate from month 1 and diverge consistently over 80 months. Importantly, the intermediate group is not a gray zone. A hazard ratio of 2.45 with a lower confidence interval above 1 means this risk is real, and these patients warrant closer follow-up and not reassurance. To summarize, comprehensive cardiac MRI integrated with machine learning substantially outperforms GRACE, STEMI, and conventional Cox models in predicting long-term outcomes after STEMI. The advantage over Cox using identical variables confirms the benefit comes from the algorithm, not just the variable selection. Beyond LV ejection fraction and infarct size, microvascular injury, RV strain, and biatrial strain each contribute independently, capturing dimensions of post-infarction pathology that no prior risk score has integrated together. The three risk tiers, 2.3%, 5.8%, and 12.3% annual MACE rates, translate directly into clinical action, and performance is vendor independent and sustained over 4 years. Thank you very much for your time and attention.